Welcome to the 7th episode of our iSense Q&A series. I am Erin Manning, the Communications Manager for the UCL-led iSense project, which is an EPSRC-funded interdisciplinary research collaboration. Our researchers are working to develop tools and technologies to track, test, and treat infectious diseases. This Q&A series is a chance to speak to and learn from experts working in fields related to infectious disease surveillance, testing, treatment, and beyond. Today we have the absolute pleasure of being joined by Prof Ann Blandford from University College London, Dr Euphemia Sibanda from CeSHHAR in Zimbabwe, and Dr Alexandra Freeman from the Winton Centre for Risk and Evidence Communication.
Hi, I'm Ann Blandford. I'm Professor of Human-Computer Interaction. I would say here at UCL, but of course we're all in our own homes, but notionally at UCL anyway.
Thanks, Anne. And Euphemia?
Hi, I'm Euphemia Sibanda. I'm based in Zimbabwe working for a research organization called Centre for Sexual Health and HIV/AIDS Research. I work for LSHTM as well. I have a joint appointment and I'm a senior lecturer in global health and epidemiology.
Thanks very much, Euphemia. And Alexandra?
I work at the Winton Centre for Risk and Evidence Communication at the University of Cambridge, where we work on information to inform but not persuade people.
Thank you so much to all three of you for joining us. Today I'll focus a bit on COVID-19 in my first few questions, but then we'll branch out to other areas throughout the discussion. And please feel free to draw on your own experience in other areas when answering any of the questions. First, I'd like to look at digital technologies for communication and engagement. So the World Health Organization says COVID-19 is the first pandemic in history in which technology and social media are being used on a mass scale to keep people safe, informed, productive, and connected. So from your experience over the last year, how would you say the pandemic has influenced and changed communications about a health crisis? Maybe Anne, would you like to start?
Sure, thank you. I think it's a really interesting question. I think the world has changed a lot in the last 12 months, both on social media and the way that social media channels are used to inform, but also perhaps to misinform quite significantly about the pandemic and indeed other health and political issues. I think we've also seen a big change in the way that information is propagated via other channels, and I hope a significant increase in digital literacy and also health literacy through all the conversations that have inevitably taken place around the pandemic, but also apply, in many, many other areas around personal health and population health.
Yeah, absolutely. Thanks, Anne. Euphemia, would you like to add anything to that?
Yes, I have similar views, and to say that what the pandemic has also enabled is to drive initiatives to communicate timely. So we are now able to see ways of engaging people in a more urgent manner. For example, decisions about lockdowns have been effectively communicated in a very timely manner to ensure quick implementation. And strategies have been developed to ensure that people can have quick meetings to communicate decisions, to come up to decisions without delay. In the past, our mode of meeting was predominantly face-to-face, but we've transitioned to a mode where we can immediately set up meetings and come up to rapid decisions through online platforms.
Yeah, absolutely. Thank you. And Alex, do you have anything you want to add?
I think there's a very good points made, and the speed of sort of data sharing has been incredible, and the breaking down of barriers around data sharing as well. Things that would have taken 2 years to get permission to share some hospital data, that's really changed. But from the public perspective, people have pointed out that here in the UK, we've changed from Saturday night television being watching Strictly Come Dancing to being watching a scientist presenting PowerPoint slides on epidemiology. So I think there has been a real change in how people approach data, both from the expert perspective and how people approach data and data sharing and the speed of data analysis and visualization, but also from the public perspective of just understanding you know, what an exponential curve looks like and what it means on the ground. So it'd be really interesting. I don't know the data, and I'm sure Anne knows it better than I do, about how this has influenced people's health literacy and digital literacy, but it'd be very interesting to know.
Yeah.
I'm afraid I can't answer that question directly because that's not quite my area either.
A topic for another day, maybe. Thank you very much for all of that. And as you say, with all the benefits of new technologies, we also know that this has enabled misinformation and disinformation, which can be harmful to people's physical and mental health. And the World Health Organization has referred to this overabundance of information as an infodemic. And we can see that misinformation can be very disruptive and threatening to health gains and reduce the effectiveness of health measures. And I wanted to ask you, what effective digital health tools and strategies have you seen that have been developed to help deal with this infodemic?
I think it remains a real challenge, actually. I don't think we have got very effective ways of dealing with it. What we are seeing is that the big social media platforms appear to be starting to take their social responsibility in this space rather more seriously than was evident 2 or 3 years ago. So there are new policy statements and new statements about the ways that they're changing their practices in order to control who has accounts on social media platforms like Twitter and Facebook, etc. And we're seeing more about how those accounts are managed and how misinformation is being moderated and perhaps blocked. But it's not evident that yet that it's particularly effective. I think, the jury is still out, in my view, on where this is going. There is that sense of Pandora's box, that once something is out there, it's no longer under anybody's control, and the misinformation, often benignly, is shared just as enthusiastically as active information. And I think some of the challenge is about kind of educating the whole population about evidence and about thinking about what is the evidence behind the claims that are being made and what are the credible sources of evidence. I think because things have changed so fast, actually, as a population, from young children through to the oldest users of the internet, actually, we don't all have very good strategies for judging the quality of information and what can be relied on and how you validate information to build a better understanding.
Yeah, absolutely. Thanks, Anne. Euphemia, I wanted to ask you, from a perspective working on HIV, from your experience, what role does education and communication play in mitigating misinformation around HIV to ensure the success of HIV self-testing and treatment and care?
Yeah, so my experience really with education is, first of all, you need to understand how the community has come to that understanding that they have. It's typically insufficient to just sit in the office and design educational materials without that understanding. So typically that necessary groundwork should be done, and with engagement of local people as well, to get that nuanced understanding of why people believe that and what sort of messages might be useful in getting them to understand. And I found that to be very useful, to communicate in using language that is understandable by the community. And also what I've also found important is to engage individuals who are trusted opinion leaders within the community, because that typically is useful in making sure that people lend a listening ear to the education or to the information that is being offered by the people that they trust. And examples of opinion leaders that have worked in this part of the world include church leaders, pastors have been good custodians of information that have enabled people to adopt more positive behaviors and attitudes, because information is coming from people who are packaging it in ways that they can understand, and is being delivered in a trusted manner by people whom they already trust as part of their communities and as custodians of correct information.
Yeah, so really engaging at that community level and getting trusted people to pass messages on. Alex, do you have anything you wanted to add to that?
Well, I think that trust element's interesting because, you know, so much rides on your trust in the information and in the person who's communicating that information. And sometimes, well, possibly increasingly in an online world, you don't actually know who's providing the information. So you can't go to that old kind of, oh, well, it comes from X or it comes from Y, so I trust it. You have to try and judge the information on its own terms, because it might have come from, you know, being passed on through channels and channels. So I think there's, well, possibly as the global community is having to learn new ways of identifying trustworthy information and looking for cues in that information itself. And I think that's, you know, that's a hard task that we've never had to do before. We've generally in the past been able to rely on the trustworthiness of the source. So I think it is something that it'll be interesting to see if people become better at identifying trustworthy information, whether it's something that we will end up teaching, you know, looking for trustworthiness in information. It's a changing world. But I think it does all come down to those trust relationships and trustworthiness of the information. You know, things like including the source information within the information itself. You know, where did this come from? You know, all of that, those kind of cues that people use.
Yeah, absolutely. Thanks, Alex. We have a question from the audience. Could we have some examples on related information campaigns and how to measure the effectiveness of them? I don't know if anyone wants to answer this question.
Can I jump in straight away then?
Yeah, go.
Immediate thoughts on that. So it depends. Measuring effectiveness depends on your aim. So this is why at the Winton Centre, and as I said, our aim is to inform and not persuade. So we're not trying to change people's behaviour, and we're not trying to change people's beliefs. So that's quite different from, say, a public health campaign, which has a particular aim in mind of behaviour change, you know, increasing vaccination or increasing take-up of a screening programme, these kinds of things. So our aims are to improve people's confidence in their decisions and feel that they've been informed about their options, these kinds of things. So the effectiveness of our campaigns, as it were, so when we're measuring the effectiveness of our communications, we have to basically get people to do surveys so we can find out whether they felt they were informed and what their feelings were about the information they provided and we provided, and what their feelings were about the decisions they were making based on that. So those are quite difficult and subtle metrics, but I'll hand over to those who have different aims with their communication.
Thanks, Alex. Anyone want to add to that?
I guess I would just add, kind of building on the point that Alex made, that actually very often what individuals care about and want to know about and how they make sense of information can often be at odds with, or not, at least not completely aligned with, the agenda often of health professionals, and particularly in public health, thinking about actually how do we persuade people to adopt particular healthy behaviours. And so there can often be quite a conflict between these two kinds of agendas of empowering people to make their own informed choice versus empowering people to make the choices that other external experts believe will be in their best interests. And those different kind of value systems can be challenging from a design point of view, but also challenging in terms of bringing together communities of people to actually design information resources that work effectively. And I haven't answered that question about how you measure effectiveness, because frankly, as Alex says, I don't know what it means, you know, what the word effective even means really in that context, because it can mean different things to different people.
Yeah, absolutely. Thanks, Anne. Euphemia, do you have anything you want to add to that?
I'll come back to the same point about the importance of context and ensuring that your communication effectively targets the audience that you are seeking to engage. And an example that I'll give from my work, my work is largely on research, implementation science research related to HIV. And we've had opportunities to create instructional materials to support HIV self-testing. And what we found that some simple terms that we thought were easily understandable by people in the communities we're targeting were not understood as intended. And what was important was to make sure that we worked with locals to ensure
I think Euphemia.
Oh, we've lost Euphemia.
Maybe.
Yes, I was just trying to work out whether it was me.
Yeah, I me too.
I think it's Euphemia. Can I pop back in, because Euphemia reminded me that the questioner had actually asked for an example. So I wanted to give an example in some work that we've just been doing around COVID vaccination, which kind of highlights the difference between your different aims and what you would think of as effective. So we were looking at communicating side effects from vaccines, and also the effectiveness of vaccines, the fact that it's not 100%. There'd been some concerns that if your information was implying that vaccines were kind of 100% effective, then people might not carry on protective behavior once vaccinated. And we were also interested in the kind of informed consent aspect of providing people with side effects data. And so we did a study where we were providing some people with the simple messages from the government about vaccines being safe and effective, versus more subtle information giving more details about potential side effects, and that 100% it's not 100% effective. And actually, we found that people who were given more information were more satisfied with their decision. They felt they were more informed, and they liked having the material, but it didn't change their vaccine choice. So their vaccine choice was, even though they now knew that there were more side effects likely than prior to being given information, because we asked them how, prior to being given any information, how frequent they thought side effects were and that kind of thing. So they had a more realistic opinion, and it was higher than previously, but it didn't affect their vaccine choice. So if you were trying to give people more information and thinking it would make a difference to their behavior, then it wouldn't be effective. But if you were trying to ensure that people felt that they'd made an informed choice, then it was effective.
That's really interesting. Thanks for sharing, Alex. Euphemia, I'm going to pass back over to you. Sorry, you just dropped out.
Sorry about that. My
no,
connection.
That's fine. Totally fine. Perfect. Maybe I'll go on to my next question, which is around misinformation and increasing stigmatization. Euphemia, my first question is for you. Stigmatization around HIV has been a concern and still is very much a concern. Can you share some examples of interventions and discussions around stigma that you've seen work both successfully and maybe unsuccessfully to encourage people to test for HIV? Maybe this follows on from the point that you were saying before as well.
Okay, so stigma is really a large topic, and I haven't done specific research to address stigma. But from my experience, we could be talking about the self-perceived stigma and also the enacted stigma. And there have been various interventions that have been implemented to try and address a stigma. And while a lot of interventions such as information giving and building the skills of individuals. It could be healthcare workers being equipped with ways of dealing with patients in a non-stigmatizing manner, or ways of improving people's confidence so that they feel better about themselves and have less of a self-stigma. A lot of these interventions have found that there's reduction in stigma, but many of them haven't translated to show the corresponding impact on uptake of interventions. Although this is a big field where a lot of research is still ongoing. I would like just to add information related to HIV, particularly in the context of Zimbabwe, where you can see that definitely the time that we've spent since HIV programs were implemented in Zimbabwe has had a positive impact in the way that stigma has been recognized in the communities. We've come from a situation where people did not talk about HIV at all. People were not able to openly discuss their HIV status, to a situation at the moment where a lot of people are able to admit that they are living with HIV, and actually there are community-based programs that support uptake or adherence to antiretroviral therapy, where people can form community action groups that can support each other in collecting prescription refills from local health facilities, because they feel comfortable in telling each other about their HIV status. And I think this comes from a perspective where communities now understand, they now have more information about HIV. There's also been a reduction in the fear, because a lot of the stigma may have been driven by lack of knowledge from people's perspective, not understanding how HIV was transmitted, not understanding that there is life after an HIV diagnosis. So this lived experience that people have with years of program implementation of HIV programs is actually seen a positive trend, where there is less and less of both the perceived and the enacted stigma in societies.
Yeah, that's great to hear that there has been
Val has his hand
a
up.
reduction. Yeah, I just saw that. Val, would you like to ask a question?
Yeah, if that's okay, Erin. Sorry, I wasn't sure about the form. Okay.
Absolutely, go ahead.
I just wanted to, hi, Euphemia. I just wanted to bounce on what you said, and in the previous, in your answer to a previous question, you mentioned that a lot of the interventions that you've have worked with involve members of the community, and for working with you and having been involved in a few projects in the region, I know that that relies on the multitude of little daily interactions within members of the community. So for example, this distribution of HIV self-tests at universities is supported by digital tools, but it will still happen because trusted students will give the test to other students. So I was wondering, in this context, I don't really know what the situation has been in Zimbabwe since COVID. I know that, you know, some of your team has been working from home, but I don't know whether it's made more difficult to carry on these interventions if people can't see each other as much. And if that's the case, if you've already thought about ways to go around this and keep, you know, this these interventions going and make sure that people still get tested for HIV.
Yes, so it's really been a challenge with the COVID-19 pandemic. For example, in Zimbabwe, since March last year, we've gone in and out of national lockdowns, where people were basically staying at home, and travel was limited to essential travel. And because of that, we've seen instances where even the most essential services were affected, because people were not able to people were not able to take up the services, even when they understood that it was essential for them to go and take up the services. For example, maternal health services, it was not always possible for them to go because transport wasn't available for them to go. So it's really been challenging. But what we've done to mitigate this is to make sure that information went out to the healthcare workers as much as possible, because one of the challenges when lockdown was introduced was also the health workers did not know what was priority and what wasn't, and whether they were supposed to turn people away when they arrived to the clinics, or whether they were supposed to prioritize certain types of patients. So that education was done. I remember mass media campaigns being given, and even government giving out information that people shouldn't be denied health services if they needed to. And I think this has worked, but still we've seen statistics, for example, in the maternal health services, we've seen that they've really been reductions in uptake of services. HIV self-testing, HIV testing in general, uptake of that has gone down. And there have been ways of trying to make sure that we try to ensure that uptake of services continues, particularly with the use of HIV self-tests, because venues like pharmacies have remained opened and people could go and collect self-tests from such venues. It's just that this is something that had not yet been developed. So just developing such an intervention as an agent in an agent format has been a challenge as well. But we've also seen, for example, with a sex worker project that we implement in our organization, that we've improved our capacity on volumes of community-based interventions, where we've actually been going out to the communities to provide the services so that people have easy reach and access of such services as self-testing, because they are not able to travel out and get these services.
Yeah, thanks very much for sharing that, Euphemia. I want to ask you, and particularly around technologies that have rolled out through the pandemic, and how technologies have adapted and extended to create new opportunities for managing health. What do we need to understand about the way people interact with technologies to ensure technologies empower individuals using them? Maybe Anne, you can give a perspective from what you've seen during the pandemic.
Yes, I think in some ways it's been quite hard to gather data during the pandemic and to track the changes for all the kinds of reasons that Euphemia has just talked about, but applying to research as well. But I think more generally, in terms of empowering people with technology, we have to recognize that we're not all the same, that some people will have different coping styles from others, will want to engage more with technology. Some people will prefer to still rely much more on health professionals. The shift, there's been a big shift towards self-management. Some of that driven by kind of positive ideals about empowering people, and some of it perhaps driven by more pragmatic issues about capacity in health services and an ability to deliver care at the levels that people would like. I mean, we've seen that particularly obviously around COVID, but around many other, health conditions through this past year, that the health services worldwide, but certainly in the UK, have been stretched, way beyond capacity. And so actually people have to learn to self-manage to some degree, because there's sort of no choice. It's kind of forced on us. But as we think about design, we need to think about designing so that it's not just relying on technology, but technology with trusted people, with experts and professionals, and community support. So technology doesn't stand on its own. It can be a really valuable complement to other forms of services, but I don't think we're ever going to design it so that the entire world is technology enabled.
Yeah, absolutely. Alex, do you want to add anything to that from what you've
No,
seen
not
during the
really. No,
pandemic?
not my area of expertise. Although I'm interested, Anne, in what you were saying. And do you think of technology more as a form of communication between people with different expertises, you know, lived experience versus academic experience or clinical experience, or do you see a role for technology in itself in thinking of algorithms and those sorts of non-human decision-making tools?
So I think where the problems are really well defined and one can build trust in algorithms that can be tested to a high standard to address defined problems. You know, for example, in some areas of medical imaging, you know, last night I was at a talk on detecting polyps in colonoscopy. You know, polyp detection is actually now well enough understood that actually the algorithms are pretty reliable, and we can have pretty good trust in those areas. Whereas some other areas of healthcare, I think there's a long way to go, and one has to recognize that the word care is actually a very kind of human word, and that there are real roles for experts and peers. And thinking about experts and peers, you know, those are different kinds of information. So what we've found in some of our studies is that peer communication is absolutely brilliant for people to kind of make sense of the lived experience, to discover what it's like to be normal in a new situation, because that's about the lived experience. And peers are fantastic for supporting communication and sharing lived experiences. But of course, what we pay health professionals for is actually to understand the science and to understand the medication and the clinical interventions. And actually those have a different kind of role and need to be communicated through technology, and can be communicated through technology in a different kind of way. But they're both really important sources of information, but they're different, and we need to understand and value those differences as well. And, you know, the means of communication may be slightly different. You know, it's much more kind of forum based, for example, if it's peer-to-peer communications, whereas there is a kind of status difference in terms of kinds of expertise of being a clinician versus being me. And that requires different styles of communication.
Yeah, absolutely. Thanks, Anne. Euphemia, do you have anything you want to add to that from the perspective of Zimbabwe?
Yes, just to say, one of the things that has been important from Zimbabwe, from our context, has been ensuring that we can package digital tools or messages that are sent through digital tools into formats that can be received even in the most basic devices. Because in our settings, in urban communities, many people have smartphones. So in general, there are no limitations to the type of messages that can be sent through those platforms. But if you wish to go out to rural communities as well, then you need to be thinking about making sure that people are going to be people with the most basic phones can access the messaging. And also in terms of whether people will engage with the message, has also been how much data required, how much data costs it would require to engage with the messaging. And if it requires a lot of data to download, then you see that people are not going to be necessarily willing to engage with the digital tools or platforms.
Yeah.
I think that's a really interesting point and really important, because so much in the sorts of communications that we've been, you know, helping design over the years, if you didn't know the audience and their technological setup, you know, you have to know what sort of capabilities people have on their phones or their laptops, but also the, you know, the Wi-Fi connection. If it's going to go down all the time, you have to be thinking about something that's going to withstand that. And yeah, these are the sorts of very practical considerations that often get left too late. You know, you've got to know the situations in which communications are going to be used early on, because otherwise you can carry on designing your strategy or your website or whatever, and it's going to be useless down the line.
Yeah, and there's also that point that Euphemia made about almost like national policy around cost structures for data. I think in the UK, we tend to buy so many data bundles that we don't really think about the costs very explicitly, whereas in many other countries, you know, every bit counts, so to speak.
Yeah, absolutely. Thanks very much for sharing that, Euphemia. Alex, I have a question for you. A lot of your research focuses on risk. What in particular have you learned about communicating risk to the public during the pandemic?
Yes, obviously there's been a fair bit of risk to communicate in the last 12 months. And one of the things that is really important to understand straight off is that risk isn't a number. So people get us mixed up with data visualization and that kind of thing, which is all about trying to communicate just numbers, as it were. But a risk is it has a probability or a likelihood component, but it's mainly an emotion. It's a subjective feeling of what something means to you. And that's driven quite a lot by what that impact would be on you. So if, for example, you know, self-isolation for 10 days, to some people, that is a huge impact because they have caring responsibilities, or it would hugely impact their income, whilst for others, it would have very little effect. And so your emotional response to the numbers associated with the likelihood of having to self-isolate, for instance, will be really, really different. And so the risk is all about feeling and subjective experience as much as it is about likelihood. So it's been really important for us to talk to people a lot about what the risks that we might be trying to communicate around COVID mean to them, and to help, because no number speaks for itself. You know, 13% chance means absolutely nothing without context. And so a lot of our work is about trying to find the best context to put around a number without, as I say, trying to persuade people, not trying to make a number look big or a number look small, but trying to put it in a context for an individual person or for a policymaker, so that they can try to put that number or that risk into their own subjective kind of understanding of the world. So it's really quite weird and quite nebulous. And until COVID struck, we'd been working with quite particular audiences, you know, patient groups, or we also work on communication in court, you know, forensic evidence. So we'd worked with quite particular audiences. We hadn't done so much work with the general public, which is a vast number of people with very different perspectives, and with policymakers as well. And sometimes the same communication has to work for policymakers as it does for individuals, like the graphics around vaccination that we did recently. So it's been interesting for us to try and understand the perspectives and the different contexts that different communities and different individuals and different people with different decision-making roles would put around these risks, and therefore to try and work out how best to communicate them to allow them to put that into their own context and their own subjective understanding. So yes, it's been a bit of a kind of accelerated learning for us, the sorts of things that we did over a longer time period, all compressed into a couple of months of quick work. But in doing that, it's also meant that certainly I personally have gained a lot more understanding about what sorts of principles of risk communication are generalizable and which ones aren't, for instance.
Yeah, perfect. Thanks for sharing. I have kind of two questions that maybe weave into one and follow on from what you've just said. So how do we communicate risk to an individual? But also there's been a lot of uncertainty around health during COVID-19. So how do we communicate to people and get them to understand uncertainty around their health?
Yeah, so the communicating risk to individuals when you know who the individual is, it's you can put it within a context that you think will work best for them. If you don't know who the individual is, then that's, you know, more tricky. But we have been doing work, for instance, on what people generally find helpful as a context. So for people's personal risk of COVID, it didn't make sense to people to say, you know, your risk of dying from COVID if you catch it is equivalent to something else like your risk from cancer, or, you know, some other disease, or even some other life event. Those weren't comparable emotionally. So what we found was that putting it into context of somebody else's risk. So people can imagine, you know, a 90-year-old with underlying health conditions. They've got a sense of that higher risk, and then they can imagine a healthy 20-year-old, and they know roughly in their subjective experience what they feel that low risk means, and then to be able to put an arrow with, you know, you are here on this scale, that helped people, we found, in general. So we've been doing a lot of work about those kinds of scales with comparator risks on it and a kind of you are here arrow. When it comes to uncertainty, that's a really interesting area, and I think it boils down into two different kinds of uncertainty. Well, at least two. I know of two that have different effects on people. And there's your kind of statistical uncertainty. So, you know, could be between 4 and 6 kind of uncertainty, and people are absolutely fine with that. And you can give people ranges like that, you know, between X and Y, or if you're doing it graphically, you can put, you know, margins of error onto plots, and people understand it absolutely fine. And they know, I mean, everybody instinctively knows that there is uncertainty around most things, and certainly around, you know, numbers of COVID cases, that kind of thing, especially in the future. The kind of uncertainty that I think is almost more interesting is the underlying quality of the evidence. So, for instance, things around, you know, how effective are face masks, these kinds of things, where you've got a lot of variability. Obviously, it depends what kind of face mask, but you've also got potentially, and I think in the case of face masks, quite low quality evidence. You know, we're not talking thousands of laboratory studies here. We're talking lower quality observational, sometimes, data. And there we've been experimenting by giving people either no label as to the quality of the evidence, or saying it was high quality evidence, or saying it's low quality evidence. And as you'd expect, people who are told it's high quality evidence trust it more, and they also think that the intervention is more effective than those who are told it's low. But those who aren't given any information behave as if it's high quality, which is really interesting, and I think brings up some really interesting ethical questions for communicators, because it means that potentially if you're not disclosing the quality of the evidence, people seem to be assuming it's high quality, which kind of makes sense. Why would you be telling them if it wasn't? So, and even, and people who were told it was low quality thought the intervention was less effective, because they're kind of taking the quality into account. And it also seemed to affect their potential behavior. I mean, this was all in a study where it was hypothetical behavior, you know, would you wear a mask or eye protection and things like that? And they were less likely to take up that suggested behavior. So as a communicator, you are potentially, if you've got low quality evidence and you're not disclosing that, kind of lying by omission. That might increase take-up, but is it ethical? You know, I think these raise really interesting questions, and obviously we're only at the beginning of that kind of research, but I think it does need doing.
Yeah, that's super interesting, and could talk about it for ages. But I am concerned that we have 1 minute left, and I would like to ask you all if that, no, that not at all. I left that question to last, but there's so much to talk about there. So I'd like to ask you all if there's one thing that you'd like everyone to take away from this conversation, or one thing you've learned during the pandemic that you'd like to share with everyone, or for everyone to keep in mind. What would it be? Maybe Anne, you could start.
So I'm going to pick up on Alex's theme about uncertainty, but a different form of uncertainty, which is that with both COVID itself and also increasingly with long COVID, what we're finding is that there are lots of things that we just don't know. And historically, medicine and medical practitioners have tended to behave like they know the answers and we have to trust them. And, you know, as patients, you know, we should be doing what we're told, we should adhere. But actually, particularly with long COVID, the clinicians don't know what's going on either. We don't have enough evidence to have confidence about any interventions yet. You know, we're starting to build that evidence base, but actually we have to communicate with people that we don't know more generally. And that's a new adventure in a kind of clinical context of admitting that there are a lot of people who are suffering from a new clinical condition and we just don't yet know enough to be able to give very authoritative or informed guidance, and that it's a journey together between patients and professionals in that context. And it's also complex. So my 2 words would be uncertainty and complexity, and managing those as we go forward.
Thanks so much for sharing. Anne and Euphemia, what would you like to sum up?
Yes, yeah, so my one is the fact that from a public health perspective, we should be aware that information is being shared. And this includes both the positive information that we would like to share and a lot of negative information that is generated from different sources, some which we may not understand. So it's important for us to immerse ourselves in societies to understand how people are getting to the understandings that they have, so that we can deliver messages and interventions to address the falsehoods and myths that are going around that could derail the public health gains that we've had over the years.
Yeah, really important. Thanks, Euphemia. And Alex?
I would say, as communicators, I think you need to think about where you are on the inform and persuade spectrum. And as Anne was saying, you know, if you have a lot of uncertainty, which we often do, maybe you shouldn't be so much towards the persuade. I would say treat your audience as adults and put your uncertainty out there and inform them and make those decisions together. Don't just think, well, this is the best evidence we've got, so we're going to be very strong about that and persuade everybody to do what we think's best on the basis of this low quality evidence.
Yeah, thank you so much, Alex. It's been a really interesting discussion, and you all got such interesting perspectives and different perspectives on the topic. So it's been great to talk to all of you. Thank you for joining us today, and hopefully we speak to you soon. As I mentioned, this is recorded, so I'll put it on the iSense website, and you can feel free to share it. Thank you for joining.
Thank you.
Pleasure to meet you all. Bye.
Bye.